Welcome to a new episode of Evidence Echo.
Today we're tackling a truly critical global health challenge, malaria in Africa. Despite incredible worldwide efforts, malaria continues to be, well, a devastating force, especially across sub-Saharan Africa. It accounts for a staggering 95% of global cases and deaths. Just think about that number.
It's a heavy burden, absolutely. And while there has been remarkable progress, a 40% decrease in malaria incidence and a 60% reduction in mortality between 2000 and 2022 in the WHO African region, that's huge. But the fight is far from over. This disease still tragically claims around 300,000 African children's lives each year. That's predominantly due to Plasmodium falciparum, which, remains highly lethal.
We're going to explore one of the most promising sort of emergent strategies in this ongoing battle. Vaccination. You've brought us some really insightful sources, recent reviews from 2023 and 2024. They summarize the latest empirical evidence on vaccine efficacy, safety, and maybe most critically, community perception. And also the practical challenges of getting these vital tools to the people who need them most. Our goal is to cut through the information overload and give you a clear, comprehensive understanding of where we truly stand with malaria vaccination in Africa.
Exactly. We'll explore not just what these vaccines can do scientifically, but, how they're being received on the ground and the complex real-world hurdles involved in widespread implementation. Okay, let's unpack this.
Right. The journey to a malaria vaccine has been, well, tough, really arduous. It's complicated significantly by the Plasmodium parasite's incredibly intricate life cycle.
It really is. Unlike many viruses or bacteria, its life cycle involves multiple stages. In humans, in mosquitoes. And it constantly changes its appearance, Makes it incredibly difficult for the immune system to target effectively. And for vaccines to provide broad protection, it's a tricky one.
But despite that complexity, there's been substantial progress. So what are the leading vaccine candidates now that are actually making a difference?
Well, the most extensively studied and the one initially recommended by the WHO back in October 2021 is the RTS SS01 vaccine, usually just called RTS S. It's primarily recommended for children from 5 months of age, and it follows a 4-dose schedule. By the end of 2021, pilot projects in Malawi, Ghana, and Kenya had already administered about 2.5 million doses. So that was a significant milestone.
Okay, 2.5 million doses. That sounds like a powerful step forward. What have we actually seen in terms of its effectiveness? How well does it prevent malaria?
Yeah, so the RTS vaccine has shown, let's say, varying efficacy. It depends on the study and the setting. In some trials, it demonstrated an overall efficacy of around 55% at 12 months.
55%. Okay.
But in the larger phase 3 clinical trials, its efficacy was somewhat lower, maybe around 36% for children aged 5 to 17 months, and about 26% for babies aged 6 to 12 weeks.
So lower for the younger infants.
Right. And its protection does tend to wane over time, so its effectiveness decreases in the long run.
That waning is a common issue with vaccines, isn't it?
It can be. But here's a crucial insight. Emerging evidence suggests its efficacy increases significantly when it's combined with seasonal malaria chemoprevention, or SMC.
SMC, that's giving anti-malarial drugs during the high season.
Exactly. Giving anti-malarial drugs to children during peak transmission seasons. And this combination, it truly highlights that a multi-pronged approach, combining vaccination with existing interventions, that's likely the most powerful path forward.
That's a current point about combination strategies. It's not just about the vaccine alone. Now, I've heard whispers about a newer vaccine that's showing even more promising results. What's the latest there?
You're likely thinking of the R21 Matrix M vaccine, or just R21. It was officially recommended by the WHO in September 2022.
Relatively recent then.
Yes. And early clinical trials, particularly in Burkina Faso, showed an impressive efficacy, as high as 77% overall, and even up to 80% among the group that got a high-dose adjuvant after a booster dose.
Okay, adjuvant. Can you quickly explain what that is?
Sure. An adjuvant is simply a substance added to a vaccine to boost the immune response to it. Makes it work better, essentially.
Got it. So 80% with the boost? Which countries are using R21?
Ghana and Nigeria were among the very first African countries to approve R21, and it's considered well-tolerated and potentially low-cost. That low-cost part is a huge advantage for widespread rollout.
Those efficacy numbers for R21 are certainly helpful. 80% is a big deal. But for you listening, a critical question always comes up with any new medical intervention. How safe are these vaccines? What do the studies tell us about adverse events?
Safety is absolutely paramount, and these studies have meticulously tracked adverse events. Can't stress that enough. The most common minor issues reported were things like injection site pain and maybe a fever. And these usually subsided within, say, 1 to 7 days. Pretty standard for many vaccines.
Okay, minor issues. What about serious adverse events, SAEs?
Right. SAEs were rare, occurring in only about 0.1% to 1% of participants, so very low rates. The most frequently reported vaccine-related SAE was febrile convulsion or seizures. This was particularly associated with the RTS vaccine in children, maybe 2 to 3 days after they got the shot.
Seizures sound scary, even if rare.
They do, and it's something monitored very closely. However, it's really important to note that most SAEs overall were deemed unrelated to the vaccination itself. They were often associated with actually getting a malaria infection or other coexisting conditions. That's a key distinction.
Right, separating the vaccine effect from everything else happening.
Yeah.
Okay. So bringing this all together, if these vaccines, RTS and R21, are widely adopted, what kind of impact could they actually have on that devastating malaria burden we talked about?
Well, if we look at the bigger picture, the predictions are truly significant. The potential is huge. At 100% vaccine coverage, which is, an ideal scenario.
A big if.
A very big if, yes. But theoretically, it's estimated that somewhere between 5.2 million and 10 million malaria cases could be averted annually, and maybe 27,000 to 51,000 deaths in children under 5 could also be prevented each year.
Millions of cases, tens of thousands of lives saved. That's massive potential.
It really is. Which leads us right into the next critical piece. What factors influence people's willingness to actually accept these vaccines on the ground?
Yeah, it's one thing for a vaccine to be effective and safe in trials, but quite another for it to be accepted and widely used by communities. What have these reviews revealed about how communities in Africa perceive these malaria vaccines?
It's a bit mixed, but the perception is generally positive overall. Many community members view a malaria vaccine as essential. They see it as necessary for controlling the disease, for keeping their children healthy, even if they understand it's not 100% effective. That realism is there.
So these are the value even with partial protection.
Yes. In some studies, more than 3/4 of participants reported overall positive perceptions. And there was a strong positive association found between that perception and their actual intent to comply with vaccination schedules. Interestingly, many even preferred vaccines over, say, traditional malaria drugs or vector control measures like bed nets.
Preferred them. That's surprising. Why do you think that is?
Maybe the perceived ease, or perhaps fatigue with other methods. Hard to say definitively, but it's a notable finding.
That general positivity sounds encouraging. So with that baseline, what do the acceptance rates actually look like on the ground? Are people getting vaccinated?
Well, this is where it gets varied. Acceptance rates vary really widely across different regions. We see numbers as low as, say, 32.3% in Ethiopia, for instance. But then you look elsewhere, like Sierra Leone, and it's as high as 96%. Huge difference.
Wow, from 32% to 96%. What drives that acceptance when it is high?
The key drivers consistently include the high perceived risk of malaria, especially in children. Parents know the danger. Also, a strong desire for self-protection and prevention. People want to avoid getting sick. And interestingly, practical incentives play a big role. Things like free consultations and medication offered alongside the vaccine have been shown to significantly boost uptake.
It's fascinating how those practical, maybe even small incentives can influence health decisions so dramatically. But okay, if the perception is generally positive, why isn't acceptance universally high? You mentioned the low end in Ethiopia. What about simply knowing about these vaccines? Is awareness an issue?
That's a critical point. Vaccine awareness is generally quite low in many places. The studies we reviewed showed it ranged from just 11% in Tanzania up to maybe 60% in Nigeria.
Only 11% awareness in one area. That's very low.
It is. And there's often confusion between malaria vaccines and other routine childhood vaccines. People aren't always clear which is which. In some areas, there was even a sort of low willingness among community members to actively learn more about the vaccine when asked.
A lack of interest in learning more. Why might that be?
Hard to say. Maybe skepticism, maybe information overload, maybe lack of trust in the source. But this lack of initial knowledge is a significant hurdle. It tells us that maybe the biggest barrier isn't fundamental resistance for many, but often just a profound lack of awareness or clear information.
Beyond just awareness, what other factors stood out to you from the research as influencing people's willingness to accept or conversely reject the vaccines?
Well, what's fascinating here is the inconsistency of some factors. It's not always straightforward. For instance, the impact of religion on vaccine acceptance. It's been inconsistent. Some findings showed, say, Christian mothers more likely to accept in one country, but less likely in another. So it's complex, tied to local context.
Not a simple cause and effect then.
Not at all. Cost, however, is a clear and consistent factor, pretty much universally. Free provision significantly increases acceptance. Increased costs clearly decrease it. Simple as that.
Makes sense. What about fears?
Yes, fears of specific adverse events, particularly those febrile convulsions we mentioned, that's been linked to refusal. And even things like unsuccessful injection attempts by vaccinators. A bad experience can put people off.
Understandable.
Beyond that, various socio-demographic factors play a role, things like marital status, region, education level, even prior vaccination experience for other diseases. And unfortunately, a significant and pervasive issue is the spread of misinformation and misconceptions. Rumors.
Right. So let's connect the dots. We have promising vaccines, RTS S and R21. We have generally positive perceptions, though awareness is low. Yet the data suggests only about 5% of people in Africa have actually received malaria vaccination so far. It seems like a huge gap.
Yeah.
What's truly preventing a massive widespread rollout? What are the big hurdles?
This is where the real-world complexities truly emerge. It's multi-layered. One major obstacle is simply limited access, pure logistics. Many African nations lack the essential infrastructure. Think about good remote access roads, reliable transport, and they lack the resources to effectively deliver and distribute vaccines, especially to those rural, often highly malaria endemic areas where they're needed most.
So just getting the vaccine physically to the people is a challenge.
A huge challenge. Limited transportation options, significant logistical hurdles, poor road networks, often made worse by unfavorable weather, rainy seasons, geographical barriers.
And beyond just getting it there, keeping it viable is another hurdle, like maintaining it at the right temperature. Right, the cold chain.
Exactly. You've hit on another key point, the pervasive lack of a robust cold chain system. This system is absolutely crucial for maintaining vaccine potency and safety, keeping them at the correct, very specific low temperature from the factory right up until administration.
And that's often missing.
In many places, yes. Countries lack the facilities, the specialized refrigerators and freezers, the monitoring tools, and importantly, the trained staff needed to maintain a consistent cold chain. This can unfortunately lead to stock expiration, wasted doses, which is tragic given the need.
And you mentioned conflict zones, too.
Yes, adding to this challenge, conflict-related insecurities in some regions make it even harder, sometimes impossible, to deliver vaccines safely to those who need them most.
Okay. Access and cold chain. You mentioned awareness earlier, but there's also the issue of limited data, right? Difficulty in tracking what's happening.
Yes, that's another critical point. It's surprisingly challenging to accurately evaluate malaria vaccination coverage across the continent, or even to precisely measure the vaccine's actual impact on morbidity and mortality in real-world settings outside of controlled trials.
Why is the data so limited?
It's largely due to a lack of reliable surveillance methods in many areas, and limited resources for conducting frequent, high-quality surveys. Without precise current data, it's incredibly difficult to identify the low-coverage areas, to truly understand the gaps in the rollout, and therefore to develop effective, targeted policies to fix those gaps.
And I guess that lack of data also makes it hard to make the case for more investment.
Absolutely. We need more real-world efficacy data beyond the initial pilot projects, and better cost-effectiveness data to really convince donors and policymakers that this is a worthwhile, impactful investment compared to other health priorities.
It sounds like funding is a common thread running through almost all of these challenges.
It really is. Limited funding is critical. It underpins so many of the other issues. Malaria vaccination campaigns are, by their nature, very expensive. There's the cost of the vaccines themselves, the delivery, the staff, the training, and many African nations simply lack the adequate means within their own budgets to finance these campaigns fully.
So that financial constraint impacts pretty much everything we've discussed.
Yes, it impacts access, running awareness campaigns, strengthening the health workforce, robust data collection. It all comes back to resources, ultimately.
Speaking of the health workforce, I understand there are significant shortages across the continent, particularly in rural areas.
Indeed. Substantial health workforce shortages exist across sub-Saharan Africa. This is a well-documented problem, and it's particularly acute in rural and isolated locations, often the same places where malaria is most prevalent.
How does that directly impact vaccination efforts?
Well, it directly impacts the ability to administer the vaccines in the first place. You need trained people to give the shots. It impacts the ability to educate the public effectively, address concerns, build trust. And to track and follow up with vaccinated individuals, ensure they complete the full schedule, it leads to longer waiting times at clinics, which can discourage people from seeking vaccination. And it significantly increases the workload and stress on the few available staff, leading to burnout.
So a stressed, overburdened workforce is less effective. Makes sense. And then there's the sheer complexity of malaria transmission itself. It isn't a one-size-fits-all problem across Africa, is it?
Not at all. This is a vital point. Malaria transmission is profoundly influenced by so many local factors. Varying vector characteristics, different types of mosquitoes behaving differently, distinct seasonality patterns, climate variations, the existence of dissimilar malaria vectors even within the same country. It's incredibly diverse.
Which makes planning difficult.
Exactly. It makes it incredibly difficult to develop and implement programs that are perfectly adapted to every single local context. For example, just knowing the optimal time for vaccination can be challenging due to these variations. Though general recommendations are usually for vaccinations to occur in the off-peak malaria seasons, typically after April, but before August for many countries, to build immunity before the rains.
And the parasite itself adds complexity.
Yes, the immense genetic variety of the Plasmodium parasites makes developing broad-spectrum vaccines very difficult. And it also makes it hard, methodologically, to isolate the specific impact of the vaccine from other interventions being used simultaneously, like insecticide-treated bed nets or antimalarial drugs.
Right, teasing apart what's causing the reduction in cases. Finally, let's revisit misconceptions and vaccine hesitancy. We've certainly seen this play out globally with other health initiatives like COVID-19. How significant is it for malaria vaccines?
It's definitely significant. We've learned, painfully perhaps, from recent history that hesitancy is a major barrier. Misinformation and rumors can spread like wildfire. Things like unfounded fears of vaccines causing infertility.
We heard those with COVID too.
Exactly. Or even more shocking, culturally specific rumors, like talk of blood theft associated with injections or vaccine scars signifying sexual misconduct. Things that seem outlandish but can take root. And a pervasive lack of trust, sometimes in pharmaceutical companies, sometimes in governments, also fuels this hesitancy.
Where do these rumors spread?
Often through social media, but also very powerfully through trusted community figures and sometimes religious leaders. Addressing this requires really careful, culturally sensitive strategies. It's not just about presenting facts. It's about genuinely building trust over time.
Okay, it's clear that the challenges are multifaceted, deeply interconnected. It really is a complex web. So let's shift to solutions. What does a comprehensive path forward look like to overcome these hurdles and actually ensure widespread malaria vaccination in Africa?
Well, it's clear this requires a joined-up effort, as they say, what the reports call a multi-sectoral approach. It absolutely demands close, sustained collaboration across governments, non-governmental organizations, NGOs, healthcare providers, local communities. Everyone has a role.
No single entity can tackle this alone.
Precisely.
So, within that broader multi-sectoral approach, what are the key areas of focus? Where should efforts be concentrated?
Okay, first and foremost, increased funding and resources. This is foundational. Governments need to allocate more, yes, but also international organizations like the Gavi Vaccine Alliance, philanthropic entities. They must commit significantly more financial resources. For vaccine development, yes, but also crucially for distribution, for public education, for robust training of healthcare workers, and for building and maintaining that vital infrastructure, like the cold chain systems we talked about.
Money talks, basically. And how do we ensure the community is genuinely on board, that the vaccines are truly accepted and utilized?
This comes down to active community engagement and participation. It cannot be a top-down approach. It really means involving communities at every single stage, right from program planning through to monitoring and evaluation. Community leaders, local health workers, religious figures, they can play absolutely key roles in raising awareness accurately, respectfully, and in dispelling misconceptions, building that crucial trust.
How do you tailor that communication?
You need tailored communication strategies. What works in one place might not work in another. Think community meetings, maybe door-to-door campaigns, using local radio, trusted local voices. It has to be culturally relevant.
Makes sense. The workforce issue you raised is significant too, and directly impacts vaccine delivery. What's the plan there? How do we strengthen that?
Yes, the involvement of healthcare providers is paramount. They are absolutely critical. They're often the most trusted sources of health information within their communities. People listen to their local nurse or doctor.
So they need support.
Definitely, we need robust training programs to equip them with the skills not just to administer the vaccines effectively and safely, but also to communicate thoughtfully and empathetically about vaccine concerns, to listen to people's worries and respond appropriately. Strengthening the healthcare workforce overall, particularly recruiting and retaining staff in rural and underserved areas, is simply non-negotiable for expanding coverage.
And bringing all these different players, government, NGOs, communities, healthcare workers, together effectively. How does that happen?
That requires broader multi-sectoral collaboration, really fostering partnerships across government agencies, health, finance, education, NGOs, academic institutions doing research, industry partners, community-based organizations. This collaboration can leverage diverse expertise and networks to find innovative solutions and overcome those stubborn logistical barriers.
What's the key to making that collaboration work?
I think the crucial question now is, how can we best share knowledge and coordinate efforts effectively to ensure everyone's pulling in the same direction, aligned with both national health priorities and global goals? We need to prevent fragmented efforts and really deliver on these breakthroughs together.
Are there technological solutions being explored to help overcome some of the logistical challenges, especially reaching those remote areas?
Absolutely. Technology offers some exciting possibilities. The utilization of new vaccine technologies is a huge opportunity. We need continued investment in research and development for, let's call them, next-generation malaria vaccines. Vaccines with potentially enhanced efficacy, maybe longer-lasting durability.
What kind of technologies are we talking about?
Perhaps using novel delivery systems like self-amplifying RNA, which can basically make more vaccine protein from a smaller dose, or nanoparticle methods, which package the vaccine components for better delivery and immune response. And there are other novel vaccine candidates like GMC2 and PFSPZ, which are still in various stages of clinical development. The pipeline isn't empty.
So better vaccines potentially coming. And to get any vaccine where it needs to go, especially to those hard-to-reach communities, what about addressing the sheer logistical hurdles? You mentioned drones.
Yes, this means exploring truly innovative delivery approaches. Things like mobile vaccine clinics that can travel to remote villages. Drone delivery systems are being trialed for vaccines and other medical supplies in some parts of Africa already. Or perhaps decentralized vaccine distribution networks, getting stocks closer to the communities. But it also requires significant, unglamorous perhaps, investment in basic infrastructure development, roads, storage facilities, and strengthening supply chain management systems overall for reliable and timely delivery right to the last mile.
It's also encouraging, isn't it, to see African nations taking real ownership of this fight, too, building local capacity.
Indeed, that's incredibly important. The African Vaccine Manufacturing Initiative, or AVMI, which was established back in 2010, its whole aim is to increase local vaccine production capacity on the continent, which can, over time, reduce dependence on external sources, potentially lower costs, and maybe even build trust within communities if vaccines are seen as homegrown.
And international partnerships remain important, too.
Vital. We've seen successful international collaborations, for example, the China-Africa Medical and Health Cooperation. There was a specific project in Tanzania under that umbrella that focused on malaria control, including interventions alongside potential vaccine rollout later. And it significantly reduced the odds of malaria infection in the intervention wards by about 66%. These kinds of partnerships, sharing expertise and resources, are vital.
Okay. Today, we've taken a really deep dive into the complex landscape of malaria vaccination in Africa. We've explored the promising efficacy and safety profiles of vaccines like RTS S and the newer R21. And we've delved into the varied community perceptions and acceptance rates, generally positive, but with caveats.
We've also confronted those formidable challenges, from limited access and funding, which are huge, to critical workforce shortages, the inherent complexities of malaria transmission itself, which varies so much place to place, and that persistent issue of vaccine hesitancy, often driven by misinformation and lack of trust.
But importantly, we've also highlighted the powerful multi-sectoral solutions being championed. It's not hopeless. From increased funding and active community engagement to leveraging new technologies and fostering local manufacturing initiatives, there's a path forward.
The progress is definitely real. There's momentum. But the fight against malaria, particularly that deadly Plasmodium falciparum, it still faces ongoing difficulties. Significant challenges remain that require sustained effort and continued innovation. We're not there yet.
So what does this all mean for you listening? It means the global health community and African nations are really at a pivotal moment. The tools, the vaccines are emerging. The scientific breakthroughs are happening. But the path to widespread, equitable access, getting these tools to everyone who needs them, is paved with these complex human and logistical realities we've discussed. It demands innovative thinking and truly collaborative solutions.
So perhaps our final provocative thought for you to consider today is this. As scientific innovation continues to accelerate, continues to give us potentially game-changing tools like these vaccines, how can we truly bridge that gap? The gap between these life-saving breakthroughs developed in labs and clinical trials, and the deeply personal, cultural, economic, and logistical realities on the ground across diverse African communities. How do we ensure every person in need actually receives the full benefit of malaria vaccination?